Hey everybody, my name is Ryan Shelton, and I'm so happy that you're interested in my talk that I gave at the San Diego Pain Summit. I do want to acknowledge that in this presentation, I used the word tribe in my slides, and after my talk, it was brought to my attention that this term can be found to be offensive and historically has been used to dehumanize people of indigenous populations. I want to acknowledge that, and I want to apologize for that. This is my mistake. Words matter, and I encourage us all to be better at using inclusive language. I want to thank you to the person who brought this to my attention, and to Rajam for allowing me the space to acknowledge it and to apologize for it and to vow to do better next time in future talks.
All righty. Thank you all for coming back in. And it's one of those funny paradoxes, I think, of the San Diego Pain Summit is that there's so many great things, and you don't want the conversations to stop, but also we have so many great speakers. So I hope you continue all of those conversations afterwards by a fire pit. I'm going to introduce our last speaker for today. Dr. Ryan Shelton has been practicing physical therapy since 2007. Before starting his own physical therapy practice, he was a clinical mentor and coordinator of a large orthopedic residency and spine fellowship program. Since leaving the corporate PT world, he focused on improving accessibility and equitable access to healthcare services. Ryan is the owner of Philanthro PT, a healthcare company focused on improving accessibility to communities that are historically and systematically shut out from healthcare services. He is focused on taking care of the people in his community, regardless of insurance or ability to pay. So please welcome Ryan Shelton.
Hello, everybody. First, thanks for having me. I'm really excited to be here for my first San Diego Pain Summit. Thanks to all the speakers earlier today. During each one of your talks, I learned a lot, and I have a completely different lens now in how I think about when I hear research. And so some of the things I was excited to hear about was, talking about how things need to be accessible and how non-English speakers are being excluded from research studies, and we'll talk about a little bit today the same things happening with folks with certain insurances and lack of insurance. So the goals of today, I want to make sure that we discuss how power differentials affect health and how they can affect our patients' agency. I want to talk about advocating healthcare providers to investigate policies and systems and processes that contribute to healthcare inequalities in your community and where you work, examine business practices that create and maintain these healthcare inequalities, and hopefully inspire some of you to create a practice that not only helps yourself, but those that you serve. So a little bit about myself. I am I identify as a small town kid. I grew up in a very small town, 2,000 people in central Illinois. I learned a lot growing up, and I've learned a lot since I've left that small town, and that really has created my business. And so today, we're going to be talking about research. I want you to think less about the research and more about yourself. My goal would be thinking about the things that we're talking about to find your community that you want to serve, and think about how the policies where you work aren't allowing you to be your authentic self and treat people in a very deep, authentic way. So first, I want to talk a little bit about my upbringing. Like I said, I grew up in a very, very small town. I remember as a kid wanting nothing more than to get out of my small town. I dreamed of the big city life. I dreamed of something more than my little farm community I felt could offer me. What I didn't realize is I spent a lot of time trying to think about, just running away and going on to bigger and better things. And then I found my tribe. So going into college, moving out allowed me to really diversify my friends, my circle of friends, my circle of ideas, and the people that I interacted with. And I really realized at that time that there was a lot of things that where I grew up, I wasn't getting the whole story about how the world worked. When I found my tribe, I really felt I was a camp counselor for a few years for people with disabilities, adults and kids with disabilities. And in that process of working with these people and meeting other counselors, I really felt for the first time I was in a place that was kind of excluded from the rest of the world. And, I was 18, 19, 20 years old, and this was the first place that I felt free to be who I really am. I didn't have to worry about what mom and dad thought about what I had to say. I didn't have to think about what my friends who I grew up with thought about what I had to say. And what I realized is I am not the kind of person that I don't want to be the kind of person that I was when I was growing up. I wanted to be something a little bit different. So as I kept going through my career, I started to climb the corporate ladder. I felt like that was the thing that we had to do to get out of the small rural town. We got to climb the ladder. We got to make money. We need to, get ahead. And what I found, I definitely didn't make it to the top of the ladder, but I went a lot farther than I thought I was ever going to go. And I realized when I was there and looking down, this is not who I wanted to be. This was not my dream. There's a lot of benefits. I became a clinical specialist. I was in an education department who just were wonderful about leadership and instilling professional development. So I wouldn't trade it for the world. But towards the end of that career, I realized something is missing. And so I stumbled across a book, How to Cook Your Life. It talks on a little bit of Buddhist philosophy, and what they talked a lot about was the supreme meal. And for me, and I don't expect this to be something that everyone's going to get into, but for me, this was the aha moment. It was the thing that really got me to think about, how do I want to live my life? Growing up, I wanted to live my life. My dream was to have a $150,000 house and be able to take my kids out to eat. I made it. So once I realized I've really made it, what do I want to do with the rest of my life? And I realized what I really want to do with the rest of my life is continue what I found at this camp that I worked at. I want to be my true self. I want to quit polishing the edges to fit into the corporate world and continue to do the things that I was expected to do in a certain way. I have no problems with the corporate world. It's meant for some people, but I realized it was not meant for me. So what I realized and what we're going to talk about today is this supreme meal. This is life. You need to have doubt, faith, and determination. I had doubts that where we are in the United States and what we are allowed to do as physical therapists is not enough. We can do better. The doubt was it shouldn't have to be like this. The faith was I can do this better. And the determination was I'm going to do it better. I owe it to myself, and I owe it to the people I grew up with. So we're going to talk about recipes today. I come from a long line of people who are amazing cooks, and so I also like to eat, and so everything in our world is about food. So recipes kind of fit nicely with life and eating. So the recipe for livelihood, we have to make money. We have to pay our bills. If you have people who are dependent on you, you made the decision to bring people into this world that you have to sustain. But we also have to serve. And in that service, there should be some social action. A lot of times we're doing one or the other, but rarely are we doing all three. So I'm here to advocate for that. And then the recipe for social change, I don't want you to think that you have to do what I do. I know who I am, and I know who I want to serve. I want you to ask yourself, who do you want to cook for? Who are your people that you want to serve? And then reverse engineer the process of making the best meal that you can for you and them. And we have to remember that when we're talking about the recipe for community, nothing exists by itself. There is no community without everyone taking care of everybody. The problem, which we'll talk more about, in the United States and other places, the recipe is me first. And what happens is the only way we can get ahead is we have to leave other people behind. But I don't think it has to be that way. It can be that way. The laws allow it to be that way. But we're going to make the case today, hopefully, that it doesn't have to be that way. So my niche. I remember when I started my business, the first thing, what do you have to do? You have to niche down. You have to figure out this small community of people who you can serve best. And I really had a really hard time, and I struggled to figure out, how do you scale down the medically underserved folks? How do you scale down to medically vulnerable populations? So in and of itself, I had a hard time thinking about, how can I know that I can serve this community, but I also have bills and a mortgage and children and dogs and now cats. So I needed to get paid. So I needed to figure out, how can we make this work? I knew that these were the people I wanted to cook with. These were the people I wanted to cook for. When I started Philanthro PT, I decided that this is not going to be my business. This is going to be my life. I hear a lot of talk about being an entrepreneur is someone who solves problems. I think that there's a lot of people that use that title in a wrong way. I think there is a lot of ready-made wisdom, just like ready-made mixes. And if you grew up like I grew up, with a mom that cooks everything from scratch, you don't want to eat anything out of a box. And that's the same way that I feel about the people who I want to serve. So you have to get into the community and figure out what we need to do to cook together. So on a little more of a serious note, we have a code of ethics. And I know that with a couple of speakers ago, we talked about the role of the things that we can do. We can talk about nutrition, we can talk about exercise. But if you go one down, it talks about the code of ethics. And what our code of ethics asks us to do, and I know that this is for the United States, and I know other countries have a similar code of ethics that ask us to look at social responsibility. And so I want to highlight here 8B, physical therapists shall advocate to reduce health disparities and healthcare inequalities, improve access to healthcare services, and address the health, wellness, and preventative health care needs of people. So I feel like with my company, this is what we were going to do. This is going to be the thing that set us apart from other people and other businesses who I felt are not doing a very good job of honoring our code of ethics. And so to talk about that, we have to talk about capitalism and the intersection of capitalism and ethics. There are financial considerations that have to be made when you run a business. I don't think maximizing profits is a problem. It would seem silly to not try to maximize your profits if you're trying to make money. I don't see a problem with cost cutting. In my business, we've gone through a lot of different services and a couple different EMR systems based on how much I feel like the value and what I want to pay. So these things aren't always bad things to talk about or think about. Obviously, we need to make sure that we pay our employees and ourselves as well. But there's ethical considerations. And the ethical consideration is we need to make sure we're providing equitable and accessible care. Obviously, we all want to talk about patient outcomes. We all care about patient outcomes. And I know that we care about denial of treatment, but depending on where you work, you're forced to deny care to people every single day that you go to work. I know it can be done because I work for a company that did this. I work for a very large corporation that started out on the East Coast, and we saw a lot of patients. Some days I'd see 20 to 26 patients a day with myself and my PTA. That's a lot of patients. And I'm here to tell you, I loved almost every minute of it in the early stages, because what we did with our profits is we gave away $6 million of free care a year for people who didn't have insurance. On my schedule, I would have patients who did not have insurance. I would have patients who had insurance. The rule was we are working for our community. So there's an intersection there of we can talk about productivity levels. There's a lot of things, but I was okay with it because I was allowed to serve the people that I really felt like I wanted to serve. With the extra profits, we built schools. The corporation built schools in Haiti, specifically so kids can have an education and, most importantly, at least one meal a day. I feel really, really good about working really, really hard to help other people out. But obviously, as corporations grow and things happen in the political climate, in the business climate, policies start to prevent us from meeting the health needs of the community. So I asked to the audience, you don't have to participate, but raise your hand if you've ever found yourself questioning the policies where you work. A lot of people are raising their hands. Sometimes we're not allowed to talk about it. Sometimes we get in trouble when we talk about it. But the fact remains, more than half of us raise their hand. So we know this is happening. So I'm not going to go too much into the research of, is this happening or not? We know this is happening. And we can't talk about helping people with healthcare inequalities without acknowledging social determinants of health. We've talked about these at length. We've heard them in the discussions earlier today. So I'm not going to go into those a lot. But what I do want to say is, what problems speak to you? Because the possibilities are endless. Whether you're a PT, whether you're an OT, whether you're you do body work, a massage therapist, however you identified, what we learned from today is that you're also an artist. Everyone drew today. So even though you may not identify as an artist, doesn't mean you can't do art. Just because you don't identify as someone who does education doesn't mean you can't educate. Just because you don't identify as someone who works on economic issues, it doesn't mean you can't work on economic issues. You have the freedom to do what you're called to do. Won't need to go too much more into the social determinants of health because the past San Diego Pain Summits, they've covered those at great length. Dr. Van Hoos talked about zip codes. It's a very important talk, and if you haven't seen it, I highly recommend. They've talked about the intersection of chronic pain and blackness and racism. That's very, very important topic for healthcare inequalities. So we talk a lot and we hear a lot about upstream versus downstream, right? So everything's on a spectrum. We have fundamental causes at the top of the stream that trickle down into the communities that we live in. We have political priorities and societal values, and that varies based on where you live, even in the United States. But these things lead to unequal distribution of power and resources. And I want to acknowledge that these are very, very big problems. Is anyone in here a politician? Nobody. This is where the magic happens. So I want to acknowledge that I'm going to be talking about things that I know will not be solved until there's a political will to do so. But until the political will allows, somebody has to fight the impossible fight. Somebody has to take care of the people who are being left behind, and that's what I'm here for. And I know there's a lot of other people who feel that way, and I hope that you think about the fact that you can do something about this. The environmental influences, those will be the social determinants of health that we had talked about earlier. And then there's individual experiences. And these experiences are very complex. They can be paralyzing, and they can be mobilizing. We've heard about people in a lot of pain who will shut down and not interact with the life that they want to live. And then there's people like me and others who get real mad about things and want to do something about it. This made me a very difficult child to parent growing up. But I have one of the things that I can't take for granted, and I can't expect you to feel about this problem like I feel, because we all have our differences of experiences. I found out at 13 years old that my father was not my biological father. And there's a lot of things you could be mad about, but the thing that I remember the most about this experience was, for 13 years, he's always been in my life since I was 6 months old. For 13 years, I was a shit. And for 13 years, I never once heard anything about not being a Shelton, not being his biological kid. And so what I feel is that if this complete stranger can treat me like family and love me like his own son, then that's a thing you can do to strangers. I heard a lot growing up, blood is thicker than water. Family's really important. But then I realized, it doesn't have to just be family. You can extend love to complete strangers. And that's the thing for me that I get real excited about. But again, I don't expect everyone to have that experience. But it had a big effect on me. Just like all of these factors have a big effect on inequalities, unequal distribution of health and wellness opportunities. A couple years ago, I came across Arnstein's ladder. And this is, I just want to acknowledge, this is a model for degrees of citizen participation. It is not a model that was built for healthcare professionals or healthcare. But the more I look at it and the more I kind of investigated what it's saying, I think it fits perfectly with what my business is trying to do and what I think we can do a lot better in the healthcare space. So who is allowed to change the status quo? Does anyone feel like they're not allowed to make changes to how things work? And that's due to power. We are all the same. We are all individuals. We should all have an opportunity to make changes, but the way that power works, some of us can't. So where you live, I want you to think about, and maybe even write this down, what inequalities, maybe one or two inequalities that you see in the neighborhood where you live that bother you, or that could be changed, whether they bother you or not. Where you work, what policies and systems are holding you back from doing your best work? If you want, go ahead and write down one or two of those. And where you practice, what policies and systems create barriers for people who need your skill set? I want to talk a little bit about some of the people who I've met along the way who really make me fully understand how power is a problem. It can be a problem, a blessing and a curse. A previous patient who is now an employee of ours, her name is Dana. She was one of us. She was in the medical field. She had good insurance. Her husband was a nurse. And then she caught COVID, and she was in the hospital, and she lost her job, and she could no longer walk in the community without using a power wheelchair. She lost her job, which means she lost her insurance. And when she lost her insurance, she needed more help at home, and so her husband, who's a nurse, quit his job to take care of his wife. Any one of us in this room would say that can't be us. We work in the healthcare system. We have good insurance. It can't happen to us. It does happen to us. So we need to think about this, not just for our patients, but for ourselves. Another story of power is our patient Lisa, who went to her doctor with some pain down into her foot, numbness and tingling, my hip hurts, my knee hurts, my foot hurts. She goes to the foot surgeon, who says, you don't need surgery. Her daughter used to be a tech at a physical therapy company, and she said, well, can I get a script for physical therapy? The surgeon said, no, I don't think it's going to work for you. So she ends up calling us because we used to work with her daughter. She says, hey, do I need a script to come see you for physical therapy? I said, absolutely not. We can see you. But for a professional courtesy, let me call your surgeon, who told me and my team, I'm not writing you a script. I don't care if she wants to come. I'm not going to write you a script. I don't need a script, a prescription from a physician in the state of Kentucky to do my job. But for some insurances, I need it to get paid. And so these little things are getting in the way of people who need us from being able to see us. And then the last story is Brian. Brian had cancer, and Brian had a lot of medical problems and a lot of medical bills, and he maxed out his insurance. He got physical therapy. He got in the door. And once his benefits ran out, he was discharged, like happens all across the United States. The problem is Brian needed a lot of physical therapy. And so without someone taking these people on, what are we doing to our communities? That's what I'd like you to think about. It doesn't take much imagination to see how these dynamics play out in healthcare. We raised our hand. We know these happen. You've heard these stories before. What we do once we gain power is we try to keep it. I am a prime example of that. I had very little power growing up. Very few people in our small town had much financial power, economic power, things like that. So once I started making good money, it's really hard to think about not making good money. We all are dealing with these sort of issues. The things that we see in the PT profession with tokenism, and for those of you that don't know, the practice of making a symbolic effort to do a particular thing is tokenism. So we do informing. And again, this is I'll go back, this is all from Arnstein's ladder. Too much emphasis on a one-way flow of information, no channel of feedback. In my experience as a coordinator of a residency program, this is the majority of patient education. I am going to tell you what you need to do, and I know best. We're going to work together, but I'm really going to tell you what to do. We also have consultation, taking surveys, and again, this is for the citizen, neighborhood meetings, public inquiries. For those of you who are working in bigger systems or government systems, we get surveys all the time. How would you like to see things change? And after a while, when nothing changes, we kind of get the story already, right? These are performative surveys. Not much changes when you're a small fish in a really big boat. Those boats don't turn very easy. And then we have placation. Hand-picked worthies into committees. So after the company that I worked for got bought out, there was a lot of frustration. We had to stop seeing patients with Medicaid. Last year, we could see patients with Medicaid, and we were making good money. This year, now we're going to lose money if we see patients with Medicaid. That didn't feel right. We were giving away millions of dollars of free care. We were building schools and feeding kids in Haiti. So it turned into a new pet project where we're going to create these little silos where our employees are going to raise money for the local community. And what happens? Wonderful things. We did coat drives. We did food drives. But no one wanted to talk about the people who we served with the coat drives. We wouldn't let them get physical therapy with us. We'll give you a coat, but we won't give you physical therapy. And that didn't feel good. That doesn't feel right. So everybody has an opportunity to make a choice. And the choice that I advocate for is partnership. But we can't be a partner until we share a little bit of power. And that's a problem for some people. I'm not saying it's easy for me either. But power needs to be redistributed. Decision-making responsibilities need to be shared. And I loved the earlier slide about the patients are the experts. So you are in control to choose the power that you want to work on. And I really want to press this point. If you don't make a conscious decision to do something, you've already made a conscious decision to do nothing. I don't know what that thing is for you, but you do. And if you don't, it's important to think about. So I want to go back to the Code of Ethics for physical therapists in the United States. Physical therapists shall advocate to reduce healthcare disparities and healthcare inequalities. And advocacy is an important part of what we do as physical therapists and beyond physical therapy. Advocacy can happen in the political arena with policymaking. It can happen in organizational systems at the national and state levels. It could be a nonprofit organization. It can be a for-profit organization, or you can just volunteer as an individual. There's a lot of options of giving back to the people who you want to serve. But I'm going to keep going back to this. Know thyself. You have to know who you are. Last year, we had a major issue with my company and not being able to bill out our claims to insurances. For 6 months, 10% of our revenue came in for 6 months. During that time, I had to wake up knowing that I am going to work, and I'm working very, very hard, and I'm not getting paid for this. And I will not get paid for this until this problem gets solved. That's why you got to know who you want to work with. Here's what I know. I know that where I live, nobody else is going to take care of the people that I take care of. If I don't get up and do the work, nobody does the work. So every one of us has a community that you care deeply about, and you have enough determination to work for. I'm asking you to really think about that. The least we can do is no harm. That's the least we can do. The best we can do is advocate for justice. How you advocate matters. I ran across a great discussion and a paper talking about the difference of outreach and inreach, and I'd like to share that a little bit with you. Outreach has a lot of benefits. But if outreach efforts are consciously or unconsciously, let me back up. These community outreach efforts can also be problematic for all involved if they consciously or unconsciously exhibit some of these characteristics. Savior mentality. I want to help these people serves the person doing the helping and not the people being helped. There's a word for it in the mission world, vacation missions or something like that. We go, we take really cool pictures, meet really great individuals, and then we come home to the comfort of our homes and nothing has changed. Outreach doesn't work well if we remain comfortable. If the outreach programs are designed and controlled by those in power, it ends up being marketing. Physical therapists all across the United States are doing screenings because it's really, really important for us to make sure that you're going to be healthy. Except most times it turns into, I'm really not going to help you unless you got insurance, so you can come to our clinic and we can make some money off you. And again, making money is not the problem. It's how we choose to make our money that can be problematic. Short-term engagement with outreach are things that make us feel good. If there's no plans or effort to build or sustain relationships, that can be problematic. If there's no discussions about power, privilege, impact of group differences, there's going to be problems. If it's a one-dimensional aim, I am helping you because you cannot help yourself, you can't have true partnership. InReach is something completely different. InReach sounds like positioning yourself to learn about the community you're serving. I don't have the answers or the solutions. I'm here to help. Tell me what you need me to do. Prioritizing the quality of your relationships over the quantity of your relationships. Using your individual or organizational currency to support equity for all people involved. Early stages of Philanthropy T, the only thing I knew about the business, and I would continually tell my wife, is Ryan Shelton has no megaphone. Ryan Shelton, the physical therapist who runs and helps coordinate this orthopedic residency program, that sounds so good on paper, but I can't do anything with that in my community. I want a megaphone, so when I see problems, I want to be able to act on the behalf of people who need help. And specific and measurable goals that prioritize sustaining relationships. InReach can also be building relationships of accountability and always reflecting on questions like, how is race playing in this decision? Are we comfortable with what happens to all people involved based on our actions and our policies? It's about celebrating our differences, our accomplishments, and continued learning. And without InReach and more focus on outreach, we end up with lack of medical services and access to treatments. At the camp that I worked at, Every single day I heard this. Who you are speaks so loudly I can't hear what you're saying. By Ralph Waldo Emerson. My daughter's name is Emerson because me and my wife love this quote. And I want to live this quote. I'm not always great at it. But you got to have goals that you can't really attain anyway, right? So we spend a lot of time talking about problems. We spend a lot of time talking about the research of the problems, but very few people talk about what we're going to do with that research. So I'm going to pivot a little bit and start discussing what I think we can do about these things. So 54% of patients in the United States reported that these are medically underserved adults. 54% of them reported that they would not be able to afford physical therapy if they needed it. So my question, we can show of hands if you're interested in participating, is it fair to expect private practice owners to serve clients who cannot afford treatments? Is it fair? Raise your hand if you think it's fair to the businesses that they have to serve patients that can't pay for their services. I think it's fair, but I understand there's few hands going up, and I understand the argument of how it could not be fair. I think a better question is what happens if we don't serve these people? What I hear a lot of why it's not fair to expect private practice owners to see patients who can't pay a full rate or can't pay at all is because, Ryan, these are people trying to support their family. And I get that as someone who runs a business trying to support my family. I completely understand that. What I have a hard time with is the thought that it's too expensive to take care of people who can't pay for physical therapy. Because the research is pretty clear. It is very expensive to deny care to people who can't pay for physical therapy and medicines and the surgeries that they need and the preventative medicines that they need. From that study, they talk about what's remarkable is that despite more than 2 decades of explicit policy aimed at increasing prevention and access to prevention, the percentiles have hardly changed. So if you think all the way back to what we talked about in the beginning of the talk, policy is what needs to change. And yet, when policy changes, things don't change. Why? We have some evidence for that. In the United States, they looked at clinics, PT clinics, outpatient physical therapy clinics, for fake patients that didn't actually have rotator cuff, but they said they did. And just over 50% of the clinics accepted people with Medicaid. The policy says we have to give the underserved folks who don't have a lot of resources can apply for Medicaid. They can get insurance. And then the business decision is we don't work with people with Medicaid. That is a business decision creating accessibility problems. So we can't always blame the insurance company, but there's plenty of fault to go around. We can't always blame the politicians. There is plenty of blame to go around. But sometimes we need to look in the mirror and see what can we do differently. Medicaid patients were offered appointments much longer than patients who had private insurance, but we know that, right? We know this stuff happens. I don't think this is new for a lot of people. I would argue this is the wrong way. In another study, they looked again at just over 50% of people, or of outpatient physical therapy clinics, will serve patients who have rotator cuff repair. And the same thing happens for the mecca of outpatient physical therapy, the ACL. We love talking about ACL. If you're going to CSM next week, we're going to talk all about ACLs. Everyone's going to say, my niche, I serve patients with ACL surgeries. That's their niche. That is like the thing that they serve. But no one's willing to say, actually, I serve patients who can pay me that have ACL surgeries. So I'm asking, when you're thinking about your niche, if it doesn't include people who can't pay inside that circle, it's not really your niche, would be my 2 cents. I serve patients with ACL problems when they can pay and when they can't. That's not a value statement. That's important to me, But I'm just asking you to really think about who do you really, really serve. And if you don't feel good about saying the part about people who can't pay, then I think it's important to really think about, are you creating the supreme meal for yourself? I'm not special. I promise you I'm not special. I'm not doing anything that my friends haven't been doing long before me. There's things that I do differently. But my friend Matt Mattingly, who runs Legacy PT, and my friend Chris, who runs BBN Physical Therapy, they were accepting patients in their outpatient physical therapy practices before I even had a company. So I'm not saying I'm the only one doing this. We know that just over 50% of physical therapists in clinics can see patients with Medicaid. There's a lot of people doing it. So then my question is, if you can't make money seeing these patients, maybe it's not the insurance company's fault. Maybe there's a problem with the way the business was structured. Maybe it's how you're using money. There's a lot of other factors that go into these things. I talk a lot about orthopedics, but this extends into all niches and populations. Patients after cancer diagnosis, cancer surgery, patients with Parkinson's, patients with TBIs, adults with TBIs, kids with TBIs, they all have the same issue that we see in the outpatient world that I live in. So I love this. The people like us do things like this. People who really care about serving all people in their community figure out how to serve all people in their community. If you want to do it, there's a will to do it, there's a way to do it. But I understand that we cannot solve our problems with the same thinking that we used to create them. So we can't play the same game and expect any different outcomes. I'd argue we can't solve the problems with the same business models that we used to create them either. So now I'm going to talk a little bit about how my company tries to take care of these problems. When we talk about increasing the accessibility of patients in marginalized groups, uninsured and underinsured are the folks that we really focus on. Some of the things that we do for patients who are uninsured, we have a sliding scale based on their family size and income levels. It's not fancy, it's very basic. We talk about how many people in your household, how much do you think you earn per month, and there's some numbers and we base it on that. We also provide a pay what you can. Everyone can pay what they can. We don't advertise it because I'm a for-profit business. So if someone wants to pay me and can pay me $10, I'm going to take it. But I want people to know that if you cannot pay for your services, we are here to provide services for you. We're also working with the underinsured. So we do direct marketing to our local PT colleagues. Some of you might call them competitors. And they're in the corporate world. They're the big chains and one local chain. And we have let them all know, please do not discharge a patient who is not ready to be discharged if they can't pay. We will take over their care. How many people do you think we've gotten? 0. How many people do you think it's happened to? More than 0? Yes. Absolutely. But it's a choice that we have to make. We also accept all insurances. If we find out that someone comes to us and they said, this place doesn't accept my insurance, we go looking for that insurance and we take on those insurances. When I started my company, I used an alternative form of payment when it was just me. I was a cash-based physical therapist and people would pay me $125, and I figured out with very basic math that I need 100. And so every time I see 5 visits, that allows me to see somebody for free. And what I really found out quickly is this is not doing anything to serve my community. It makes me feel good. I love telling people about it when I first started, I promise you that. But it wasn't helping people. So I realized I had to play the game that everyone else is playing because I think we can do it better. And I wanted to have proof that we take insurances, the same insurances that you take, and we can make it work. We also use alternative forms of payment like bartering. I've gotten a lot of records from patients who couldn't afford physical therapy. I've gotten soap, some really pretty good tea here recently. And so there's a lot of things. I'm telling you that if you don't regularly find yourself in communities where people are marginalized or people don't have a lot of funds and resources, there's a lot of people that cannot afford physical therapy who do not want handouts. They don't want a handout. They don't want free care. They want to pay for their services. They can't pay for their services. So we need to honor people. I had a hard time with this in the beginning. No, we got it. Don't take care of it. And the first time someone didn't show up, he told me. I thought he wasn't going to follow through. He needed me, right? I have a service that he needs, but I wasn't listening very well. And he said, I'm not coming for free. So we started bartering people. We also provide mobile PT services for patients who are homebound that don't have nursing needs. We get a lot of calls from people that my home health therapist doesn't really do anything when they come here. So we need someone that'll do a little bit more with us. And that's no knock on home health. That's just the experiences that I'm hearing about where I live. We also use mobile PT services for those social determinants of health of people who have transportation and childcare needs. We also provide pop-up clinics, is what we call them, where we go to shelters, we go to gyms, we go to community centers, and we bring our equipment for the people there. If you're online, I know you've heard we meet people. You've got to meet people where they are, as long as they come in your door. We could do that better too. We provide telehealth PT services to help people outside of our mobile network who are living in Kentucky. And we had to get a little creative at times where there was a big need during the pandemic in one of the homeless shelters that we partner with. And so I would go. I didn't have the time to be at the clinic at the shelter all day long. So me and my kids, we'd go drop off my kids' tablets, which they were not big fans of, but that was a learning opportunity for them. We dropped off their tablets so then later in the evening or later in the weekend, we could provide telehealth services for them. How many do you all, raise your hand if you got a tablet laying around that you don't use very often? These little things can be a big difference, can make a big difference for people. So we do a lot of in-reach. In-reach is very, very important. We think the collective sense of responsibility doesn't rely on my business. We want to create partnerships and relationships. So we offer employment opportunities for our patients. And we really focus on the people who are unemployable or do not have the ability to work currently. So Dana is a previous patient of ours. And Dana is not at a place where she can have a full-time employment. But we know there's so many great things about people. If you want to go fast, go alone. If you want to go far, go together. And what we've realized is everyone in town knows Dana. So now I don't do marketing anymore. I pay Dana $50 for every meeting that she sets up for me. And Dana comes to every meeting with me and introduces me to everyone in town that I've sent emails and emails and emails to, and no one's gotten back to me. I get FaceTime with her doctors. I get FaceTime with her social workers. And we've been able to create a network that I never could have done by myself until someone like Dana worked for us. We do resume building. So we run a lifting program for one of the shelters who has a recovery program. And it's just for guys as it gets started. And these fellas are sitting in a room that is about the size of this space over here. And they can't be with the general population in the shelter because they're in recovery and there's, people they need to stay away from. So seems like a pretty miserable existence to live in a little room. So we go and we offer, we partner with one of the local gyms, the CrossFit gyms, and we bring them to the gym once a week to do an hour's worth of healthy lifting, creating better habits. But at the same time, I'm talking to them about aches and pains, people who are living in the shelter who's limping. Who have you talked to that's got a shoulder problem? So we're trying to create those partnerships with people who are not doctors, people who are not the physicians who are sending us our patients. And I'm letting them know all I need is one patient from you, from the shelter, and then you officially work with Philanthropy PT. So when you leave the shelter and you're finished with the recovery program, you can put on your resume that you worked for Philanthropy PT. And that's how I get to use my power in the community. We try to make people who are unemployable employable. And as a physical therapist, I never thought that I would be doing things like this. You would have, when I first learned about the social determinants of health, embarrassingly, maybe 5-6 years ago, I look at that like, what? I got the health thing, but man, everyone else better do all that stuff to the other side. There's a lot of things that we can do to help these folks. And then using our currency of power, we're having future discussions with, will be a future discussion with the Chamber of Commerce. My team is amazing. I reached out to my team and said, hey, Dana, who is in a power wheelchair, went to get information for us, and the building is not accessible. And so the people at the desk talked to Dana while she was outside and wouldn't even go to the door to talk to her, and that's irritating. So my thought was, I don't know if we should join the Chamber of Commerce until they fix this problem. And I brought that to the team because I can say some things that get under people's skin sometimes, and I don't want to make the Chamber of Commerce too mad, or so I thought. And then my team said, Ryan, I think we could do better than that. I think we just need to join the Chamber. And for those of you that are join the Chamber, what happens when you join, you get 5 minutes to present your business. So we're going to join the Chamber and explain to everyone how excited we are to work with the construction workers and the concrete people, because in the next year, we're going to remind them about the American Disabilities Act and that all these places need to be accessible to people. And it's important for the community, but this is my employee now. So as a business, because I have a business, now I have a bigger megaphone. We also had, unfortunately, one of the recovery guys went back to jail. So we're working on trying to find him some legal counsel, because I can't understand for the life of me how someone who wears an ankle bracelet can only stay at the homeless shelter, doesn't get picked up, misses his court date, and so they throw him in jail for missing a court date. That seems like something really easy got mixed up there, and so we want to do something about that. So long-term sustainable relationships. We work with the Beacon of Hope Emergency Shelter, the Gathering Place Mission, which is another homeless shelter. Employment Solutions, we started working with a group of people who provide day programs and employment opportunities for adults with intellectual and physical disabilities. And what we're finding out is they come back from the hospital and then they can't go back to their work, but they don't have any medical team that can help with them because they're wards of the state, and just some people don't have people looking out for them. So now we partner with them that when people need our services, we bring our services to their facility as well. And we're really excited about new opportunities with Elizabeth's Village, who works with women who are fleeing abusive relationships, the Amen House, who runs the food pantry in our town, and very excited to be able to start working more upstream with the Bariatric Surgery Center to help folks beyond physical therapy, helping them with weight management, weight loss, diabetes, metabolic disorders as well. So this is what I get asked about all the time. How do you make it work? First, you got to make it work, then you get to make it pretty. So this is what we do. My company, Philanthropy PT, we put 20% of our profits into a fund to fund my employees for next month for people who can't pay for services. So we will be moving to an open management system where you will be able to go online and you will be able to look at our books. You will be able to see how many patients we see. You'll get to see how we allocate our money. This is the thing that I realized after I got out of cash base and into the insurance system, is that more people need to know about this, because a lot of people think the wrong thoughts because that's what we were told. No one has investigated for themselves. I went cash because people told me you can't make money seeing people with Medicaid, and so I believe them. And then I started looking at what you get paid, and I'm telling you, in Kentucky, Medicaid pays as good, if not better, than United Healthcare. And guess what? Everybody works with people with United Healthcare where I'm from. So it's not a money thing all the time. So this is how we make it work. My goal is, after expenses, I need $3,000 to manage my family's finances on top of what my wife brings home. And once this happens, I will be moving out of the day-to-day operations of the business, and we'll be creating a 501 nonprofit to help even more and have a little bit more impact what we want to do. And the reason we want to work in the for-profit space is because that's where the inequalities are coming from in the physical therapy world, among many other things. So we want to be the example that if you want to make good money and you want to take care of your community, we want to let people know it can be done. The nonprofit side is where I get to go compete through donations in the marketplace of the bigger corporations. And I'm very, very excited about that. But there is no health equity without health justice. So there's a couple ways we can look at equity and justice for community engagement. We can enhance the effectiveness of an intervention. We see this a lot in the research. We want to make the intervention better, but the intervention has already been planned out. It's research, it has to work that way, I get it. But with a social justice focus, that's when we can start helping the community take care of themselves, ourselves, because these are the communities that we live in. The best method to enhance engagement is one that shares power and not just focused on enhancing outcomes, although outcomes are extremely important. So what does this justice look like? It looks like access. It looks like equity. It looks like human rights. It looks like sustainable policy. And it's improved delivery of healthcare services for the marginalized community. So access to resources is a fundamental principle. You're not doing anything justice if you're denying care to people. If you believe, like I believe, that healthcare is a human right, then we have to think about the way that business is being done currently in the United States. Equity is often confused with equality, but those things are not the same. Things that are equitable are not always equal. I'm not a company that is focused on equality. I have no problems giving more services and working harder for the people who don't have services than the folks that have a lot of resources. At some point, my business, depending on staffing and productivity, there are going to be people that we have to say we don't have a spot for you. And I'm telling you, the way my business works, it's going to be the people that have private insurance is who we're going to turn away, because they have 6 or 7 options in my town. If you have Medicaid, you don't have as many options. So that's the difference of equality and equity, as I see it. I'm not here to say I know what's best for your community. I'm not here to say that what I've just presented on is the best way of doing things. What I'm here to say is I know who I want to serve, and I know how they're being hurt, and I know what I can do to make it better. That's what I've chosen to do. I know a lot of people we're helpers, right? We help people. I know that somewhere down there, you got the same feelings that I do about helping people. You don't have to know what you're doing before you start. I'm suggesting we take the leap, because the truth is, most of us discover where we're heading once we get there. And you don't have to start a business to make an impact. Well, we learned from community health care centers, they don't know what physical therapists do. They don't have physical therapists to refer to, and they have very limited knowledge on screening and assessment tools to help people with mobility problems. So every physical therapist, and I would extend to occupational therapists and beyond, can do something about access. So we're getting close to the question time, so I'm going to just leave this slide up. But the last thing I just want to say before the questions is I want you to create your supreme meal. You have an origin story that is going to make you amazing. You have a tribe that can support you, and if you have a little bit of doubt and a little bit of faith and a lot more determination, you can take the leap to do something about it. Something that sustains you, that serves people, and has a little bit, at least a little bit, of social action to it. Thanks.
Alrighty, so I know that we have Disrupt OT coming up, so we have time for one question if anyone has it.
So I think the word you were looking for, I'm short.
Can you take off your mask as well?
Sorry. The word you were looking for was voluntourism, and if you're a researcher, it's health equity tourism.
Thank you.
So I wanted to thank you for the work that you're doing and also just sharing. Sorry, this is like really hard to tiptoe.
You can
Yeah.
maybe. Yeah,
Okay.
rock star.
I just don't want to drop it. It's going to fall. And just being really transparent. And the work that you're doing and the work that I know everyone here wants to do is individual. And so, like, how do we get enough people to give a fuck so that we can have, like, collective action and, like, systemic change? I'm not saying it's a Band-Aid. We have to do these things. But, like, how do we change it systemically and get enough people to care? Yeah, it's number 8 or whatever, but people really don't care enough to do anything about it.
Yeah, I think that just giving a fuck and being open about what you really care about will bring people to you. I think all of us really care, but we're not open about it. Sometimes because where we work, we can't say what we feel. Sometimes we can't say because of a lot of other factors, so we don't say it. And if you don't say what you're about, then your tribe is never going to find you. So I think the first step is actually doing the work of giving a fuck. I'm so happy you said that, so I get to keep repeating it. I think that's the start to find the tribe. And then the only way this doesn't work is if you quit. That's the only way it doesn't work. And I don't have the way to make sure that you know you might have to try a couple different times. We've had 3 iterations of my company, and there's been a problem every year that we ran into. So I feel like on year 3 this year, and I've said this to a couple people, this is the first year that I get to really run our playbook. So things keep happening, but you just have to go with the flow with it. Things come, when it comes to community work, there's always going to be problems. If you go into the problem knowing the solution, it'll never work out. If you walk into the situation, I'm here to help, and you keep showing up to help, things organically grow that way, I believe. And that's how it's worked for us so far. Great question.
All right, so thank you so much for a great presentation. All right, it will not hurt my feelings if you're gathering your things while I make the final announcements. Okay, so 1, thank you for coming. We will see you tomorrow. Don't forget to sign out in the foyer if you want your credit from California. So do not forget to do that. You can purchase access to the recordings of the talks for only $50. The only talks not being recorded was Dr. Hoag's today, Morton's, and Dr. Isom's tomorrow. So there's just 2 of the talks that will not be recorded. Do not forget Disrupt OT happening at 6:30. If you didn't RSVP, grab your food. 7:30 PT after dark. And then tomorrow, because Rachel Softness couldn't be with us, everything's going to be moved up, so we will be done at 5 o'clock tomorrow. Okay, have a great night. Have fun.
Yeah, absolutely.